once you get started in the ER, I would say that the most important thing, especially as a new grad, is to make sure. I'm Rodeline Joseph. I'm a PA here in Atlanta. I've been a PA for over 4 years. Most of my experience has been in emergency medicine and urgent care. So today, well, I'm going to be hosting the PA eShadowing, so I have a guest every session. But today, actually, I'll be a guest and a host. I'll be talking mainly about my experiences in the ER. Since I love the ER and I've done about over 2 years in emergency medicine. So how it'll work is that, like I said, I'll be hosting it and I'll have a guest. The guest will, of course, discuss a little bit about their career and like the day-to-day activities. And then we'll give you guys a chance to go over a case study, 1 or 2, if we have time. And then, of course, answer any questions that you may have. So just as I said, I've been a PA for over 4 years in emergency medicine. I'll get right into talking about the ER. The ER is a little different actually, before I get into that, I want to actually thank Dr. Gray. He's in charge of all this. He created med school headquarters, and he's the one that thought of the opportunity to have PA eShadowing. So a big thank you to Dr. Gray for even thinking about us PAs during this time. And he is trying to add on other professions too. So yes, the ER. The ER is a little different for PAs versus MDs. PAs and NPs. NPs are nurse practitioners. There's different PAs and NPs are considered APPs, APCs, or MLPs, and they're all the same thing. APPs, advanced practice provider, MLPs, mid-level provider, and APC is advanced practice clinician. And like I said, they're all used interchangeably. It's just a name given to nurse practitioners and PAs. So you'll hear that a lot. And as far as emergency medicine, does anybody want to specifically get into the ER? If you want to be in the ER, just leave a comment and anything that you want me to discuss specifically related to the ER. So the ER is different. To me, it's a kind of a systematic way of, there is a systematic way of doing things, but it's like kind of, you have, as far as like the note taking and assessment and everything, it's systematic, but it's like, what do you do once you do all of that? What do you do once you do order the labs and you get your results and determining where to go from there? So I like to discuss a lot of that. And yeah, so we'll head right into it. So you'll be able to see a lot of the same patients as that the doctor sees. And most of the time, it's probably, I would say 80 to 90% of the same diseases or presentation of or complaints, I would say. And the level of acuity that you would see is determined by the ER, but most of the time PAs see anywhere from acuity of 3 to 5. So I'll discuss the level of acuities. Level 1 is patients that are basically like cardiac arrest, come in cardiac arrest, are basically kind of dead on arrival. And then level 2 are sicker patients. They'll likely be in the ICU. And then level 3 is like kind of in the middle. They're sick. They may go home. They may not. Level 4s and 5s are considered more fast track, and that's where a lot of the APPs are. And so fast track is like, common colds, ear infections. A lot of the kids that are typically well that come in with like mild symptoms are seen in fast track. So PAs, like I said, typically see levels 3 to 5, and the level of acuity is assigned at triage. And so they assign the patient, you see the patient, and the first thing I like to do as far as once you see the patient is kind of determine, what are you going to do with this patient? Is the patient likely going to go home, or are they going to stay? And that'll be determined by, of course, different things can happen. You might get a blood test back that you didn't expect, but for the most part, you'll kind of have a feeling or an idea of, where the patient's going to go home or stay. And so based on their vitals, based on their complaints, their history, what you gathered from your assessment. And then, let's see. All right. So once you get started in the ER, I would say that the most important thing, especially as a new grad, is to make sure that you get sufficient training. Make sure that you typically training can be like 6 weeks of shadowing a P, not shadowing, but working under a PA, where you'll go over the history and physical with that PA. Every case with the PA or an MD. But what I say is to do this until you feel comfortable, to the point that, you kind of have an idea of where you're going, where you're going in terms of treating the patient, and run it by the doctor. It's better to know what you don't know. So, you see what I mean? Like, so if you don't know a disease, always run it by the doctor. Don't think that, you're going to try to treat this patient, or you're going to try to Google it or whatnot. It's best to just cover yourself, take sufficient notes, and make sure that it's okay, that you cover all your bases. And doing this, you'll also have a better idea of, where you're going, as far as like, if you present to the doctor and they're like, yeah, this is what I would do. And then in your head, you're like, oh yeah, I would do this too. So you're on the right track. And do this until you're comfortable. When I started off, it was about, I did probably, I'd say like 3 to 6 months of training, where I would always go over cases with the physician. So like I said, do this until you're comfortable. Let's see. All right, some people ask, what's your favorite part about being in the ER? I love learning. That's why I got into the ER. I love constantly learning and seeing new things. The difference between the ER and a lot of specialties to me is that, you're always seeing something new. You don't go into the specifics of things. Like if you see a cardiac patient, you're not going to know everything cardiac related, but you're going to know what's important as far as, what can likely kill the patient. I like to, see the patients, assess them, and then kind of treat them, and then, send them home or admit them. And in the ER, it never gets boring. You're constantly seeing new things. You're constantly learning. And yeah. So, like I said, the level of acuity is typically anywhere from level 3 to 5. 4 and 5 are fast track. Level 3 is in the middle. A lot of them will be level 3s. And so those are the case studies that I'm going to go over today. I'll go over a common one that you'll see. There's a lot of common things that you'll see. ER is kind of, I would say, not to put a bad name on the ER, but you'll see a lot of like non-emergent cases. A lot of the time, it's patients that come in with conditions or complaints that can be either seen by primary care or kind of treated at home. So you have to kind of always reassure them. But then of course, other times you actually have difficult cases where you'll have to run it by the attending or, of course, admit the patient. So I'll go over first a case that you commonly see, and then the second one is a zebra. Does anybody know what a zebra is? Oh, well, okay. So a zebra is something that's not common. That's like just probably like 1 in 1,000. Like you may never see it in your career, but when you see it, you got to know it. Like you got to know, oh, I can't miss this. Oh, this can kill a patient. Oh, this is something that I always got to remember. That can be a zebra, or just like anything that you just don't want to miss. So a zebra, I'll go over a zebra tonight. I don't want to say what it is that I'm going to go on the case study is going to be. So yes, rare, uncommon. Okay, so what I want to do in order to make this more interactive is actually have somebody come on to walk through the case study. So let's see, does anybody want to come on live and walk through the case study? And I see a lot of you asking questions. I'm going to set some time aside at the end to go over questions, but I first want to, of course, discuss the case studies and what it's like being in the ER. Does anybody want to come on? If you want to come on to go over a case study, then just let me know. You would raise your hand to speak. All right, Rafi. So we're going to go over a case study.
Okay.
And everyone just kind of listen on it as we go over the case study with Rafi. Of course, it's not for any of you to know the diagnosis or disease or differential or labs to order. It's to mainly get a feel of how we do our history, physical, how we kind of assess the patient. Okay, so this case study is going to be for pneumonia. Okay, pneumonia is very common in the ER. Okay, and most pneumonia, I would say you can send home. Most of them you can send home. And especially this time of year, you'll see a lot of it, being that it's getting into cold and flu season. Most of it, like I said, you can send home. But it's determined by the patient's age, if they have any comorbidities or illnesses, how long they've had it, if they've tried any outpatient medications or failed outpatient antibiotics. So so we're gonna go over pneumonia, and what I'm gonna have you do is I'm gonna ask you the questions. So you're gonna act like you're a patient.
Okay.
Yeah, and I'm gonna ask you the questions. So listen to the questions and how I ask for the questions, okay? Not necessarily the exact question, but the who, what, when, where's, and whys of the question, and then we'll go over it afterwards, okay? All right. So just introduce yourself, and I'll introduce myself, and then you introduce yourself as the patient. So, what is your name? You want your name to be and age. Give yourself a name and age.
And 30.
Okay. It doesn't have to be your real name though. All right. So, hi, Crystal. My name is Rodeline. I'm the PA. I'm your PA for today. What brings you in today?
So I'm having symptoms where I have a cough and I feel like there's something sitting on my lungs. Have shortness of breath.
Okay, good. So I'm gonna, take pauses in between. So even though I told her pneumonia, she knew that the symptoms that come with pneumonia. So that's a good thing. All right. So it's usually a cough. So how long have you had this cough and shortness of breath?
Like a week.
Okay. And do you have how long? And have you taken anything for it?
Just over-the-counter cough syrup and Tylenol.
Okay, is it a dry cough or productive? Are you coughing anything up?
No, it's dry cough.
Okay, does anything make it better or worse?
Worse the cold. What makes it better is drinking warm stuff.
Okay, that's fine. So you've had it about a week, and I'm sorry, what did you say you took for it again?
Over-the-counter cough syrup.
Oh, did that help?
A little bit.
Okay, good. Anyone around you been sick?
Yeah, my husband.
Okay, do you have any medical problems?
I'm a diabetic.
Okay, do you take any medications?
No.
Okay, so do you know, are you a type 1 or type 2 diabetic?
Type 2.
Okay, and you're not on metformin or insulin or anything at all?
No, I'm just watching what I eat.
Okay, and do you have a primary care doctor?
Yes.
Who follows you and tracks your diabetes?
Yeah, and I see an endocrinologist as well.
Okay, good. And so you said that it feels like something's on your chest, or?
Yes.
Okay, is that like chest pain?
Not chest pain, I just feel like heaviness.
Like it's having a hard time taking a deep breath?
Yes, it hurts to take a deep breath.
Okay, all right. And so let me see if I'm missing anything. All right, so before I would even see this patient, of course, we would have our set of vitals. The triage nurse does all that. So you tell me what your vitals would be.
So my pulse would probably be elevated. So my heart rate, I'm thinking would be in the hundreds.
Okay, that's fine.
104, 105, maybe.
Okay.
My respiration, I would say, is probably 24 to 30, maybe.
Okay. So you're breathing a little fast.
Yeah. My blood pressure is normal. I don't have a fever, so so I would say 98.6. That's it, I think.
Okay, you said your blood pressure. Did you say your temperature?
Yeah, my temperature is normal. I don't have a fever.
Normal. Okay, and what about your oxygen saturation?
Oh, my 97.
Okay. Remember you said that, you're really having a hard time breathing.
Oh, yeah. Sorry. So I have shortness. Okay. So it'll be like 87?
Okay, that's really extreme. But no, I just want to say that because some patients will say certain things and it might not reflect on their vitals. So patients could be like, oh, I have a pain of like, 20, but they look fine. Or they could say, oh, I'm really having a hard time breathing, but their oxygen's 100%. And it could just be the anxiety and stress of being in the ER.
I'm
But
one of those patients.
it's good that you said that though. Okay, so your vitals, the only thing off is your respirations and your oxygen saturation. And if her oxygen's at 87, you want to quickly get her, get respiratory involved, get a breathing treatment. Especially if it's 87, you would likely go to the main ED. And I didn't mention this earlier, but I only didn't really mention it because it varies based on the ER that you work at. There's main versus like fast track or where the APPs are. Main is typically where the doctors work as far as and this just goes for when I was working or when I work. And then the other side is where the nurse practitioners and PAs work, which is also called, it can be fast track or it can just be the APP side. So, and they determine where they're going to put a patient based on their presentation and their vitals. So if a patient has an O2 stat of 87, they would go to the main. Okay. So let's probably do like 94, 93.
Okay.
Okay, so you come in, you look like this. I ask you these questions, and then the physical. For the physical, so I'll kind of run through it this time. You don't have to ask me answer anything. So I'll start by listening to the heart and lungs. Say I listen to the heart and lungs. Heart sounds good. Rate is good. Rhythm's good. Nothing abnormal. No murmurs. And then lungs. I listen to the lungs, and I hear something strange. Okay, I'll just say something strange. There's different types of breath sounds. It can be crackles, wheezes, rails. So for the sake of this presentation, I'll say it sounds funky. It sounds abnormal. Okay, so I know right then and there that I'm going to want to order an X-ray. Her vitals aren't perfect, and her lungs sound weird. I want to see what's going on. If you told me that, you've had it for like 2 days, you're, 30, you don't have any medical problems, you look good, you're breathing fine, and I could just treat it like, I wouldn't even treat it as a pneumonia. I would treat it as, it's likely a virus at that point. Typically it becomes bacterial when you've had it for, it's lingering on. You want to make sure that it doesn't progress to bacterial, and you want to do an X-ray to make sure that's not pneumonia. So most of the time, most colds and coughs are usually upper respiratory before they get to lower respiratory where you're thinking of pneumonia. So with you, I would order an X-ray and then do some blood work, especially telling me that you're diabetic, you have comorbidities, just to determine, okay, is she going to be okay to go home, or am I going to need to admit her? And has the pneumonia progressed to something worse like sepsis? Okay, you always want to cover your bases.
Can I ask you a question?
Yes.
I'm sorry. So since I'm 30, would you do a pregnancy test?
Yes. If all women, I always do a pregnancy test.
Okay.
If they come in for something simple and they're in the fast track and they tell me, my period was 2 weeks ago, and they know exactly when their period is, or they tell me they've had a hysterectomy, and I can confirm it, and they know for sure that they're not pregnant, then I'll be okay. But always do a pregnancy test, especially if you're ordering any imaging.
Okay.
Okay. So, so we're going to do an X-ray, and the X-ray, of course, will show like something like, they'll phrase it as an opacity. And that just basically means there's something, going on, and it's likely pneumonia. And it's going to be at a specific area of the lung. Sometimes it can be both sides of the lung, like double pneumonia, bilateral pneumonia. And then, or it can be just one side. Say for you, it's one side. But your vitals come back. I order a breathing treatment for you. I have respiratory, do the breathing treatment, and it's not, you're still not improving. Your saturation's still a little low. And then your labs come back, and your white count is, let's say, 20. So you have a high white count. So that means that your body's basically not, fighting in the way that we want it to. We don't want we don't want you to decline. We don't want you to just go home and be worse or go home and have to come back. Okay, so what I would recommend in your case, and then say your white count is 20, and then your blood sugar is like 400. So you're uncontrolled diabetic. You're not taking medicine. You're kind of trying to deal it with diet, but it's not going well. So I would definitely think that you're a candidate for admission.
Okay.
Okay. When I first saw you, when I saw your vitals, I was like, if her O2 stats 94, then okay. But then you also said that your heart rate was a little elevated. So we want to make sure that it's not progressing to sepsis. And that's another reason I would probably order some other labs to make sure that it's not sepsis. But overall, like, I would admit you start you on antibiotics, call the attending physician or the internal medicine doctor to admit you. And that's basically it. Of course, I'm just kind of being like super general, but I'm not going into super like all the details of it, but that's basically how it goes. You see the patient, look at their vitals, ask them questions, ask them, what did you notice about the questions that I asked you?
What do you mean?
Like, being that it's about pneumonia, was I asking you things? Was I asking you, oh, did you vomit? Was I asking you, oh, do you have a belly pain? Did I ask you, oh?
No, you asked me things that were related to it.
Exactly. So it's a focused exam. So when we go to the ER is quick. You have a lot of patients to see, and typically you'll see probably 20 plus patients in a shift, and it's an emergency case. They're all emergent. You got to treat all of them like this is an emergency. So you don't want to stay in a room with the patient for 20 minutes or so, kind of asking them all these questions. You want to focus on it, reel it in, get to the meat of it all, okay, and find out, okay, what's really going on. Okay, so that's a difference between, like, a big difference between emergency medicine and like family medicine. Okay.
So you focus on the chief complaint they came in for, and you're not just so when you do like internal medicine, you ask them everything under the sun to figure out what may be going wrong, but not the actual chief complaint. Am I getting it right?
Well, with internal medicine or family medicine, like a hospitalist, for instance, once you admit the patient, you want to know as much as you can about the patient.
Okay.
So,
but in ER, it's different.
Right, you're going to ask a lot more questions to see who else you need to get involved, like if you need to consult anybody else. And then for family medicine, you want to know everything about the patient, because that's going to be your patient that you're going to see frequently. Okay, so but then for the ER, like I said, it's emergency. It's an emergency. You got to find out what's going on, and you got to find out quick.
Yeah.
Okay? And then you don't want to ask anything irrelevant too.
Okay.
Okay, so you want to ask things that'll help you get to the diagnosis, that help you form that differential. And the differential is the 3 different diseases that you have in mind based on the questions you ask and what the patient's told you.
Okay.
Okay, and then that'll also help you determine, what you're going to order, what treatments you're going to give, and of course, what your plan of care is going to be.
Sounds good.
Okay, so let's see. I'm just gonna see what everyone is thinking. What did you guys think of that? What did you think of that, Rafi?
Honestly, I liked it. It gave me like kind of a feel of what to expect, kind of. I liked it because I liked the way you asked me questions. So I came in, I said, oh, I have shortness of breath. But my my oxygen levels were okay, So like you said, some patients come in and they say like, oh, my pain is 20, but they look fine. But then you go more in depth and you do more labs and more things like that, and you find out more about what you're actually presented with.
Right.
Oh,
yeah, and a lot of times, just make sure you're listening to the patient. You'll find out a lot of what you need from, listening and then doing a physical.
Mm-hmm.
And always take into consideration the patient's history, like comorbidities, the fact that you have diabetes, puts you at a higher risk for developing pneumonia and for getting a bad infection or developing into a bad infection. Okay, and I'm speaking a lot of like common terms or layman terms because I'm not sure if you guys understand a lot of medical terminology just yet. I don't know where you guys are with your application cycle and everything. So, so yeah, do you have any questions?
I don't.
Okay, good.
Thank you.
No problem, of course. Great. All right. So what did you guys think of that case study? At what point would you check the vitals for a second time? As far as checking the vitals, the nurses or paramedics. Paramedics do work in the ER. EMTs or paramedics work in the ER. The paramedics actually work more alongside the advanced practice clinicians, which is the PAs and nurse practitioners, and they would check it about like every hour and a half or 2 hours or so. It varies, but they always make sure to update the vitals. And if I notice that the vitals are crazy, like right when I see the patient, like say their O2 sat is 87, I'll go and do something about it. But then at the same time, I'll tell the nurse or paramedic, oh, can you recheck the vitals too? And then of course, always check them before the patient leaves. Anybody else? Oh, yes, OPPQRSTA. I'm sure. I'm glad that you guys got that. That's the style of obtaining a history. It's onset, pain, quality, what relieves the symptoms, timing. It's all the different questions to ask when obtaining a history. Yeah, OPPQR, and you'll learn that in school, and that'll help you, of course, with the ER. Let's see. Any other questions? All right, so we're going to go on to the second case study. And this case study is actually going to be something that I actually treated, and it's going to be a zebra, as I said. And we'll discuss this more in depth, too.
Hello.
Hi, Karen.
Hi, how are you?
I'm good. How are you?
Doing well.
All right, good. Thanks for tuning in.
Of course.
Okay. So, are you currently applying to PA school?
I'm in my sophomore year of undergrad.
Okay, awesome. That's great that you already know that you want to go to PA school or have that in mind.
Yeah, I'm really excited.
All right, good. So, we're going to do something similar to what we did with Rafi. Okay. I'm going to tell you what the diagnosis is. This one is a little harder, but
Okay.
I'll guide you and I'll tell you, kind of what to expect with this diagnosis. Okay. And then of course we'll discuss exactly, what this is and why it's different from, something more common as pneumonia and why, kind of how you would treat it and questions you would ask. Okay. So this diagnosis is meningitis. Although meningitis, you'll see that in the ER. There's specific types of meningitis that are not common at all, like fungal meningitis. Okay, and this diagnosis is fungal meningitis. Okay, so you give me an age and a name for you.
Okay, so I'm 30 and my name is Donald.
Okay, so you're 30 and you're Donald. So Donald is fairly young, so we wouldn't expect anything to be wrong with Donald. Do you have any medical conditions?
Nope.
Okay, so Donald's coming in, and what are your vitals? Think about meningitis. Do you know what meningitis is?
Vaguely.
It's an infection. Okay, it's a infection of the meninges. Okay, and it's bad. It's like a neural infection. So with meningitis, you'll typically have a fever. You can be confused. And let me see what else. Kind of just let's say you have a fever. You have a fever, and your heart rate is a little fast. So give me a temperature and the rest of your.
Okay. So I've had a fever of about 100 degrees. My heart rate's higher than what it normally is, just resting. Everything else has been pretty normal.
Okay, so let's say your heart rate's like 95, and then your oxygen's 98. Okay, and you said, what was your temperature?
It's been running about 100, 101.
Okay, all right. So You come in, hi, my name is Rodeline. I'm the PA. I'm going to be taking care of you today. Sometimes you can give a patient a handshake. Some patients don't like that. Some patients do. Maybe you can get the feel of the patient, reach out and give them a handshake. I'm sure now because of COVID, you're not shaking hands.
Yeah.
But as long as you introduce yourself and your title, then you should be good. And a disclosure, a lot of patients will call you doctor. Okay. And what I typically do is just inform them that I'm the PA, and I say I'm the physician assistant, which is a provider, and I'm going to be taking care of you today. Okay. So what brings you in today?
So my temperature has just been running high. My heart has been beating fast, and I just wanted to make sure everything's okay. I haven't been really feeling normal lately.
Okay. Well, okay. So with meningitis, a key to diagnosing that is that you'll have a headache, and you can have some neck stiffness, okay, and a fever. But a key symptom is a headache, okay? There's some symptoms patients will come with where oh, I gotta rule this out, okay? So say a patient comes in with shortness of breath, like the last patient. So like the pneumonia, shortness of breath. If I hear that, I'll think like, oh, make sure it's not a PE. But a PE is a pulmonary embolism. But then she'll tell me other things to, take that out of my differential. But so I want you to say that you came in with a headache.
Okay, so I came in with a headache.
Okay.
Really
and
bad
it's
headache.
a bad headache.
Mm-hmm.
Okay. So how long have you had this headache?
It's been there for a little while now, like over a week.
Okay. And how bad is it scale of 1 to 10?
It's been getting worse, so it's about a 6 now, 7.
Okay. Say like 9 or 10.
9.
Okay. And be like, oh my gosh, it's such a bad headache.
You gotta help me. It's so bad.
Yeah. Okay. That's going to help you think about, because the patient's presentation is what's going to help you think about all these differentials too.
Mm-hmm.
Talking to the patient, how they're looking. Because if a patient's just sitting there like, oh, I have a headache, you're going to be like, okay, are you lying? Or like, is this really, a true headache?
Gotcha.
But if the patient's just sitting there in the dark and they say they've had a headache, this world's worst headache of their life, and, they're not feeling well, then that'll help you, think of meningitis.
Mm-hmm.
Okay? So, or other things that can kill you. Okay? So, you've had a headache, it's a 10. Okay. And do you have any other symptoms with this headache?
A little neck stiffness, some nausea.
Okay. All right. How many times have you vomited?
In the past day, about 4 times.
Okay. And have you taken anything for the headache?
I've just taken aspirin.
Okay. And has that helped?
Not at all.
Okay, good answer. Okay. And do you have a history of headaches?
No.
Okay.
Just sometimes, like here and there. Nothing this bad. This is the worst it's ever been.
Okay. And any changes in your vision?
No.
Okay. Any I'm not gonna say seizures. Any changes in your vision? Any chest pain?
No chest pain.
Okay. Any facial droop or weakness?
Nope.
Okay. Any changes in your speech?
Nope.
Okay. Any do you feel like hazy, like you have trouble remembering things?
A little bit.
Okay. All right. So I think I forgot to do some of the ROS last time, but this time remember to do the ROS, just asking like a bunch of questions to help bring in the diagnosis. Okay, and kind of try to ask questions specific to that. So if meningitis is a neurological condition, you want to rule out other neurological conditions. Okay, so I kind of asked some stuff about stroke. Okay, to also make sure it wasn't like a TIA or anything like that too. Okay, so with the last patient, being that I knew it was a pneumonia, I kind of missed the ROS, but that's what you want to do. Okay, and the ROS would also be focused. Sometimes you can ask from other kind of body systems if you have other things in mind. But try to ask questions that'll, like I say, hone into that diagnosis. Okay.
Gotcha.
Or bring in a differential, and differential is usually 3 diseases that you have in mind. Okay, so the headache, and you've had a headache for over a week, it's not getting better. It did ask you some of the RS. So now we'll do a physical. And then I'm not going to go too detailed with the physical because usually it'll be like a neurological exam. So first I'll probably do like a stroke assessment, have them take a look at their face, stick their tongue out, smile, check for any facial juice, raise their eyebrows, take a look at their eyes, check for make sure that the pupils dilate on both sides. And then I'll listen to the heart and lungs. I always listen to the heart and lungs no matter what they're coming in for. That's just something, it's so easy. And then you never know what you'll find, listen to heart and lungs. And I'll also confirm what you hear, your vitals. So if the patient is tachycardic on the vitals, and then they listen and the heart rate is fast, and that also confirms it too. So it helps to always listen to the heart and lungs. But as far as the physical, I would do a neural exam, and then I would do check your neck. Okay, if you're saying you've had a stiff neck, and then that's basically a key finding of meningitis as well. Okay, and I do all that, and I find that, but then you have a seizure. Okay.
Okay.
So you have a seizure while I'm assessing you.
Okay. Yeah.
Okay. So you have a seizure while I'm assessing you. So what would you do?
As the PA or as the so I guess you would just clear the area to make sure they don't standard seizure protocol, just make sure they're not gonna hit their head as best as you can, clear the area and then just let them ride it out. And from there, then I guess you would have a major symptom of meningitis.
Okay, yeah. So, you would do all the things for to treat the seizure, and then that happened, that also helps bring in that, oh my gosh, this is possibly meningitis, because that's another key finding of meningitis. Okay, so you would treat the seizure, and then he didn't tell you that he had a history of seizures, right?
Mm-hmm.
So that's something new.
Yeah.
And medicine, or especially the ER, things are going to happen. Even though it's a systematic way of doing things, you got to be ready for for whatever that's going to come, and you got to know how to handle each task that comes on to or every new thing that's thrown at you. Okay, so you treat the seizure, and then what I did in this case is that I got in contact with the patient's family to find out about their seizure history, if this has been happening recently, and it was happening. So that really helped me think about meningitis. Okay, so then you order labs. There's specific labs and tests that you do for meningitis. The key one being a lumbar puncture. Okay, and then with a doctor usually does that. So being that this is a zebra, what would you do as a PA?
Is this after all the tests are ordered?
Either before or after.
Okay.
What order you can, but what would you want to do as the PA?
So I definitely want to hold them in the hospital.
Okay, way before that.
Okay.
This is a zebra. This is something that you're not used to treating.
So, get a doctor.
Yes. Yes. You want to get your attending involved.
Mm-hmm.
Okay? You want to make sure this is something that that can definitely kill a patient. Okay. If you're treating something that can definitely kill the patient, as a PA, you want to get a doctor involved. If you will have patients that have that come in with NSTEMIs, non ST elevation myocarditis, basically a heart attack, and it's just how it's presented on the EKG. You'll have patients with that. You'll have patients with pulmonary emboli, can have multiple. You have patients that are unstable. Any patients like that, you want to get a doctor on board, and you want to note that, notified physician, discuss this with physician, that a doctor is on your note. Because if something were to happen with that patient, that's you. Okay, so you want to make sure that you always have a doctor, because you don't want the patient this is an unstable patient. Anytime you're dealing with an unstable patient, make sure that you consult with the physician. Even if you know what you're doing, just at least let the physician know, I'm have this patient, I just want to keep you inform you about it, just so in case there's any questions, just in case anything happens. Okay, even if I would say even if you're a seasoned PA and you know exactly what to do, I would still like if it's like a zebra, if it's the patient's unstable, the patient's going to go to ICU or whatever it is, then I would. Okay, and
Yeah,
especially as a new grad.
definitely.
Yes, it's going to be the attending physician in the ER. You'll be assigned to an attending, not necessarily assigned, but there'll be a bunch of doctors working at once, and then you choose which doctor you want to work with for that shift. That's how it usually is. Okay. Sometimes the doctors will have too many PAs working with them, so you just choose another doctor, but you always have a doctor that signs off on your charts. Okay. So you get the doctor involved. You inform the doctor what's happening. The doctor is going to do the lumbar puncture. Usually, well, if you're a new grad, you're not going to be doing lumbar punctures. You can get trained to do it. You can have a doctor teach you. You'll learn the basics or how to do it in PA school, but it's not something that you're going to constantly be doing. So I usually have the doctors do any lumbar punctures that I have to perform or that I order. So the doctor does that. And the test results come back with basically showing that the patient has meningitis and has a fungal meningitis. So fungal meningitis is, like I said, it's not common at all. So what would you want to know?
So I want to know their travel history.
Yeah, okay, that would be a good one.
Um, I'm not really sure of the nature of how you would get the meningitis, but maybe look into other like factors that could have caused it.
Okay. Okay, so yeah, you would want to know the cause. You
Yep.
definitely want to know the cause because, you know, it's not something that's common. It's not something that everybody can get.
Hmm.
So you want to think about, oh, does this patient have something that's causing this meningitis? And you ask the patient if, you know, their medical history, they say no. So now it's not as straightforward as the pneumonia one, right? You're seeing that,
Yeah.
right? So now
Yep.
you gotta go, and this really happened to me, guys.
Oh my
So
God.
now you gotta go and kind of ask the patient about all their history, their family history. It becomes a little bit less focused now because you're trying to figure out what is going on with this patient. So, and this is something that can happen, you know, on a shift. So I found out that the patient, and this was from consulting with the doctor, because I didn't know, I knew a little bit about meningitis, but I didn't really know. So when the test came back showing fungal meningitis, the doctor said, "Oh, this patient has HIV." And I'm like, "No, he didn't say he has a history of it," but the doctor said, "Oh, that's when they usually have it when their immune system is, you know, shot, they're immunocompromised, they're at risk of getting opportunistic infections." Okay, so and you didn't know this about the patient, but doing all that is what
Yeah.
led to it. So it's kind of working a little backwards. So you did this, you found out you did an HIV test, it came back, the patient has HIV. So now you know, it's two things. It's meningitis and then it's HIV. At this point, that's likely AIDS, you know, causing this. Now you have to talk to the patient. The patient's parents are in the room. The patient is 30 years old, you know. So now it becomes like now you kind of have to probably get social work involved and it becomes like a social or social issue too. And how would you kind of approach the patient and kind of discussing this with the patient because it's a sensitive topic? What would you do?
Um,
I'm sorry, somebody said, did the patient know? The patient did not know they had this.
well, I'd be very calm. Make sure they're in like a comfortable environment. Talk slowly. Just be really respectable because it's definitely a sensitive topic.
Right.
Yep.
So the patient's family is in the room. So, you know, you'd have to ask the patient's family to leave, and then you sit the patient to this, you know, side. I think when that happened to me, I think the physician ended up telling the patient. It was me and the physician that went in the room. But we, you know, sat the patient aside and, you know, informed the patient. And then at that point, also, the patient had several seizures, and eventually he had to be intubated. But at that point, the mom was basically like the power of attorney and in charge, so she was in the room. But if the patient's alert, can make their own decisions, and then I would, you know, talk to them, have the family members leave, or ask the patient if they, you know, feel comfortable with family being in the room as you discuss their the findings. Okay. And anytime you talk to patients, it has to be in a non-judgmental, you know, manner. Okay, you do it. Don't do it like, oh my gosh, you got HIV, this and that, or you're gonna die. You gotta, be sensitive to the topic. Okay, so how would you tell them?
So I saw someone in the chat said start with the positives first. That seems like a good idea. So I would tell them like, oh, so we've done it. We ran the test. We found out the source of what's causing the seizures.
Okay.
So it turns out you have a fungal meningitis. But also one of the lab results came back that you have HIV.
Okay. Let's see. It turns out I wouldn't say a lab result. I would say, the test did show that you have a rare form of meningitis, which is typically found when your immune system or your body can't fight off certain illnesses. And after doing some more tests, we found out that this is what the results that we came back is that you had your HIV positive, and of course give them time to grieve, give them time to react to it, and answer any questions that they may have about it, and kind of appease them, make them feel okay that we are going to treat you, we are going to start you on some medication to get you feeling better. And I would still always remain optimistic, put the patient at ease. They're already as stressed as it is, and they're in a stressful environment, they're really sick. Okay, so good job. Great.
All right. Thank you so much.
Huh? I'm sorry.
Thank you.
Oh, no, great. So just want to keep you on a little longer. With this patient, like I said, the patient ended up having multiple seizures, and the patient had to be intubated. And being that it's a fungal meningitis, it's so rare, we didn't even have the medication in our ER. They had to be transferred to a different ER, which you'll learn about transferring and when the patient needs to be transferred. So they had to be transferred, and they did end up passing away. So that's something, that you have to know, that meningitis, especially a rare form like that, most patients will pass. I mean, you're not going to tell the patients that, but knowing that as a PA, okay? And that happened to me. That happened to me like 2 months into the ER. It was like, and the only reason I knew that it was meningitis because the patient was behaving so strange. The patient was behaving very strange. Like I went in there and I was asking their name and trying to get a history, and it was a fairly young patient, so I wouldn't expect that from someone so young. And I'm like, something's off, something's going on. And then the patient had a seizure right in front of me. Of course, I didn't handle it. I was kind of like thrown off, and then there was a doctor walking by, and I immediately pulled the doctor. I was like, help. We like, it was a crazy day. It was a very crazy day, and not everything was straightforward, which is of course is expected in the ER. It was really amazing to see. You won't probably ever see that type of meningitis when throughout your career, maybe once or twice, but it's very rare. So like I said, even though the ER is a field that's become something where you kind of know a lot of what you're going to see, there's common stuff like abdominal pains, chest pains, headaches, or general migraines, pneumonias, coughs, colds. There are things that you have to be prepared and trained to treat and assess. Okay, so that's one thing to, of course, know as a PA. Right? Do you have any questions?
I saw one in the chat that came up. So you seem like you really know what you're doing with your patients, like especially in like this tough situation, how to approach them, because you can't just be blunt with it and just say, like, how did you learn that? Is it something that just came along with the job, or is it like through schooling, a combination?
As far as like being comfortable talking to the patients, or
just like the proper way to do it and like what you found worked.
As far as like bedside manner, that's kind of my personality. I'm very like caring, and I like to listen to people. I'm not gonna say that it's like based on personality. You kind of learn as you go, and then of course you'll learn in school, and then and just also by assessing and treating a lot of patients, you'll get the feel of their different personalities and how far to go. But I would say to just always, always approach patients with a non-judgmental manner. Always be nice, smile, treat them like they're your family. That's what I always think. Always treat them like you're treating a family member.
That's great advice. Thank you so much.
No problem. Thank you.
Thank you.
All right. Have a nice day or
You too.
night.
Thank you.
Okay. So how did you guys like that one? Okay. I know. So I'm sure there's a lot of questions. We have about 7 to 10 minutes left. How did you guys like that one? What would happen if the physician? Okay, I'm gonna answer some questions now. Loved it. Was super cool. Good. All right. And throughout like all the eShadowing sessions, I'm gonna try, like I said, be very basic with the way that I talk because I don't know how far along you guys are with the with your medical terminology. And maybe I'll say terms just so you guys can get used to it. But actually, let me know what you guys want me to do. You guys want me to speak in medical language? You guys want me to be more general? So let me know because I don't want to say things where you guys just don't understand. So. Okay, good. So someone said, what was some of the reasons why I went into PA school? Well, this is my reason. I went to PA school because, of course, it's less expensive than the MD route. So in less education, I'm not gonna say less education, less school, as opposed to, another 12 years of school, being an MD, 4 years of medical school, then residency, then fellowship and whatnot. I just thought it was best for me to, do the 24 months and then get to working. And of course, I didn't have that many student loans. Excuse me. I'll be honest. I accrued about a little over 80,000 in student loans, and that's from my parents helping me. So it was like probably 85,000. So that's my reason. Everybody has their own reason. Just kind of think about where you want to be in life, where you see yourself in 10 years, and what works best for you. Yeah, I've seen a lot of crazy cases. Let's see. Any other questions? Do you enjoy your job as a PA? Yes. And you're gonna figure out where you want to work when you start PA school. I thought I wanted to be an OB, and I did not like it when I did the rotation. So once you get on rotations, you'll get a feel for what you like and where you want to eventually work, because that's going to determine really whether you like your job or not. How realistic has it been to pay off your loans? I think like doing the 10-year plan will help with paying off loans. I still haven't finished paying mine off. So I would say 5 to 10 years, maybe 10. You can explain the terms, that would be helpful. Okay, yeah, okay, I'll speak in with more medical terms, so we can get an idea. Okay, I'll do that. I'll do that more. All right. The acronym, okay, I'm not sure what that is. I'm just looking through the questions, guys. I'm glad that you guys like that case study. You'll learn in PA school that about the zebras and about things that you don't want to miss and about what's going to kill your patient. Of course, a lot of that you'll see in the ER. So if you decide to do like family medicine or OB or whatnot, there's little stuff, that you don't want to miss, but the ER is like the bulk of like zebra land. Okay, I'm glad you guys liked it. Would you say your work-life balance is good? Yes, I would. When you start off, it probably won't be good. You have to get used to seeing a certain amount of patients at a specific time. You have to, I would not suggest you take your work home, but when you start off, you will be taking work home. You will be doing a lot of your charting at home. I say when you start off, carry a clipboard with you. Carry a clipboard around everywhere you go. When you see patients, write down patients, write down little facts about or things you should know and remember about the patients, because you're not going to finish all your charting in one shift. You're going to take it home, and having that clipboard will help. And then, of course, create a systematic way of doing things. And that's based on what you decide to do. So me, when I'll go see a patient, I'll see like 5 patients at a time. And I've learned to kind of memorize what each patient tells me. So I'll see 4 or 5 patients at a time. Then I'll go sit down, work on those 4 or 5. Then I'll see another 4 or 5 and whatnot. And by work on, like, I'll start ordering labs, start ordering medications on the patient, and you know, that's the way that I do it. But it's really based on how you want to do and what works for you. Yes, the meetings are every Monday at 7. Well, the PA eShadowing. Usually I'll have a guest on, as I said. Today I hosted and kind of interviewed it. So it was a little bit all over the place, but it'll be a lot better once we have a host. But I hope you guys liked my case studies and overview of the ED. Do you guys have any questions specifically related to the ER? Do you guys have anything specifically related to the ER? We'll have plenty of times to answer general PA questions or PA school questions. Yes, PAs can definitely switch specialties, and that's why also a lot of PAs decided to go the PA versus MD route, is that you don't need any further training to switch specialties. I mean, of course, you'll get the on-the-job training, but you don't need any formal education. What shift did you work? I started off day shift and then I went to night shift. Typically, if you work night shift, you get paid a little more. Surgical PAs in the ER. Actually, the PA that I did one of my rotations with, he was initially in surgery and then became a PA. And then I had the PA from one of my jobs. She was an ortho PA and then became a PA in the ED. How do you handle your emotions? Emotions and working in the ED. It's a little past time, but yeah, this is an important topic. So this will be the last question I answer. If you guys do have more questions about the ED, you can feel free to email me, Rodeline Joseph at medsembly.com. I'll write that in the chat. But I want to answer this question about emotions in the ER, because you see a lot. You'll see psych cases, you'll see suicides, you'll see people that come dead on arrival, you'll see a lot of trauma, you'll have to transfer patients, you'll see a lot of kids that are, drownings, you'll see, it's a lot of trauma. So as far as like emotions, of course you have to, I don't want to say not have emotions, you want to, and I don't want to say have a poker face, because you definitely don't, but it's, kind of all based on timing, and you kind of have to be that rock for your patients. You want to be sympathetic, but you don't want to seem like unstable, or that I would say you don't want to seem like you can't handle it. Okay, so like the meningitis case was a bad one, but when I was in PA school, I actually there was a baby that drowned. The baby came in, the baby was dead. And it was like one of the worst things that I'd ever seen. And it was terrible. It was very traumatic. So I would never, it's okay to cry, but I wouldn't necessarily cry and, just kind of cry in front of a patient. I would console them and talk to them and spend, more time kind of being there for them. But I wouldn't cry in front of them. I wouldn't show too much emotion or get too involved with it. Don't get too involved with your patients, lives, or because there's so many of them, and it's not to sound insensitive, but it's just that you kind of just get used to it. Get used to that, this is kind of how life works, but then you always also have to be human at the end of the day. I'm not sure if I answered that, but you have to definitely have a strong exterior being in the ED, because you'll see a lot, but just don't be too unstable. Have that happy medium. The ER, it depends how, as far as the how fast you see patients, it depends on that specific ER. Some ERs see 50,000 patients a year. Some ERs see 100,000. The ones that usually see 100,000 are usually big ERs, and they're super busy. I work in the second busiest ER in Georgia, and it's really, really busy. Sometimes there could be like over 300 patients a day. And then usually you see at least 20 patients as a PA, 20 or more patients they want you to see. So if you have harder patients, harder cases, it'll take you longer as opposed to fast track. Fast track, you'll probably see like 30 patients, but they're like in and out, like colds, coughs, ear infections, stuff that you don't need lab testing for. Yay. So like I said, you guys can email me. I hope that this was helpful. Please let me know how you liked it. I'm gonna get the for moving forward, there's gonna be a PA from every specialty that's gonna come on. I'll let you guys know ahead of time the specialty for that upcoming week. So if say we have like an ortho PA or neurosurgery PA or just any OBGYN PA, I'll let you guys know. And you, of course, is going to be along kind of the same type of flow as far as them introducing themselves, then discussing about their certain specialty, then going over a case study.